Welcome to online anesthesia video of the week. Today topic is presented by Dr. P.NAGALAKSHMI MD.DA. She is currently working as professor in Department of Anaesthesiology at Sri Manakula Vinayagar Medical College, Pondicherry. She did her MBBS in Tirunelveli Medical College and DA in Madurai Medical College. She has completed her MD from Thanjavur Medical College. She has published 8 papers in various national and international publications. Being member and past secretary of ISA during 2020-21, she is very much active in conducting academic activities. Her area of interest are airway management, cardiac anesthesia and regional anesthesia.
Good morning. I would like to thank Edward sir for this opportunity to discuss a session on initiation, maintenance and weaning from ventilators. I'm Dr. Nagalakshmi, Professor, Department of Anaesthesiology from Pondicherry. So I would like to discuss about how we put a patient on, why we put the patient on mechanical ventilation, how do we maintain the patient, and how do we wean the patient from the ventilator. This is a basic academic session where you understand why the patient has to be put on ventilator, what are the clinical parameters, what are the subjective parameters to put the patient on ventilator. So the learning objectives of this presentation is, what are the indications, what do you define as acute respiratory failure, a few case scenarios, the initial ventilator modes and settings, and weaning protocol, spontaneous breathing trial, and what is weaning failure. So now the objectives of mechanical ventilation, why the patient has to be put on mechanical ventilation, can be divided into physiological objectives, clinical objectives, and laboratory parameters. Now, what are the physiological objectives, or why does the patient require a mechanical ventilation? It is initially to support or manipulates the pulmonary gas exchange, that is alveolar ventilation or alveolar oxygenation. Alveolar ventilation is the ability of the patient to achieve an eucapnic ventilation, that is carbon dioxide washout, and alveolar oxygen is to maintain the adequate oxygen delivery to the tissues. Or to increase the lung volume. That is, if the patient has an atelectasis, to prevent or treat the atelectasis with adequate end inspiratory lung inflation, we put the patient on mechanical ventilation. And to reduce the work of breathing. This is in cases of cardiac patients or post-anesthesia care patients. So the patient will be deeply sedated or paralyzed, and to support and to reduce the work of breathing of the patient, we put the patient on mechanical. These are the physiological objectives why we put the patient on ventilation. So the clinical objectives are to reverse the acute respiratory failure and respiratory distress, to reverse hypoxemia, to prevent or reverse atelectasis and to maintain the FRC, to prevent respiratory muscle fatigue, to permit sedation and paralysis, and to reduce the systemic or myocardial oxygen consumption, and to minimize the associated complications and to reduce the mortality. So now, how do we define acute respiratory failure? Acute respiratory failure is defined as the inability of a patient to maintain his PaCO2, PaO2, and pH within acceptable limits. And hypoxemic respiratory failure is where there is a severe ventilation perfusion mismatch, diffusion defects, shunting, alveolar hypoventilation due to age or inadequate inspired oxygen. Or it could be because of the hypercapnic respiratory failure, that is the ventilatory failure, that is the inability to wash out the carbon dioxide. And because of the failure of the ventilatory center, third one is the failure of the ventilatory center. It is the inability to maintain PaCO2 because of the central nervous system disorders, neuromuscular disorders, or disorders that increase the work of breathing. So the increased work of breathing may be due to chest trauma or pneumothorax, hemothorax. So here, even though the respiratory centers in the brainstem are intact, the ability to maintain the effort to breathe is seriously compromised. So the patient tries to compensate by increasing the minute ventilation or increasing the respiratory rate. So minute ventilation is tidal volume into respiratory rate. When the tidal volume is not achieved by the patient, then he tries to compensate by increasing the respiratory rate. So now, when we talk about the clinical and the physiological parameters, we have to have some laboratory values to indicate ventilation. So those are defined by the pH, PaCO2, and dead space to tidal volume ratio. So these are the measures of ventilation, and the measures of oxygenation are PaO2, AE, that is alveolar arterial oxygen difference, and ratio of arterial to alveolar PaCO2 and PF ratio. So the critical values are if the pH is less than 7.25, or if the PaCO2 is more than 55 and it is increasing, and if the dead space to tidal volume ratio is more than 0.6, then we put the patient on mechanical ventilation. We understand that the ventilation is severely compromised, and we put the patient on ventilation. Now coming on to the oxygen part, if the PaO2 is less than 70 against a normal value of 80 to 100, or if the alveolar oxygen gradient is more than 450 with oxygen, or if the PF ratio is less than 200, we understand the oxygenation part of respiration is severely compromised, and then the patient might require ventilation. So now there are the ventilatory mechanics which indicate mechanical ventilation. These are the parameters which are measured by spirometry. So maximum inspiratory pressure, expiratory pressure, vital capacity, tidal volume, respiratory frequency or respiratory rate, and forced expiratory volume at the first second, and peak expiratory flow rate. So these are the ventilatory mechanics, and if they are compromised below a particular value, that is the critical value, they may indicate the need for mechanical ventilation also. So this can be measured by the spirometer, a handheld spirometer, or a pneumotachymeter. So I would like to share a few case records which indicate mechanical ventilation. Here is a 23-year-old woman who was taken to the hospital after ingesting an unknown amount of drugs and alcohol. She was found unconscious, and in the emergency department, she was unresponsive to verbal commands. Her pulse rate was racing and 124 beats per minute. Blood pressure was 80/50, and the respiratory rate is 15 breaths per minute. Respirations are shallow. So the breath sounds reveal bilateral coarse crackles in the bases, and the ABG values indicate PaO2 of 60, which is lesser, PaCO2 of 69 millimeters of mercury, which indicates that is carbon dioxide accumulation, and the pH is 7.24. So the second case is a 30-year-old man who is admitted to the hospital emergency department, who complains of weakness of limbs, tingling of hands and feet, and lack of coordination. 2 weeks prior, he had been treated for a flu-like viral illness. The respiratory care practitioner obtains a basal ABG value and respiratory mechanics, which was initially within normal limits. That is, maximum inspiratory pressure is minus 70 centimeters of water, and the vital capacity was 4.3 liters against a predicted 4.8 liters value. And over a 36 period, he started deteriorating, and the patient was monitored over every 3 to 4 hours, and values progressively decreased to a vital capacity of 2.5 liters, which is 44% of the predicted value, and a maximum inspiratory pressure of minus 32 centimeters of water. And a repeat ABG evaluation on room air shows a PaO2 of 70 millimeters of mercury, PaCO2 of 48, and a pH of 7.34. So a worsening status also indicates mechanical ventilation to prevent the mortality in the patient. So now the third case is a 15-year-old girl with a life-threatening exacerbation of asthma who has been treated in the emergency department with oxygen, corticosteroids, Heliox, and beta-2 adrenergic bronchodilators. She has a respiratory rate of 37 breaths per minute, and her breathing was labored. Bilateral inspiratory and expiratory wheezes were present in both the lungs, and the peak expiratory flow is 70 liters per minute, and FEV1 was 0.75 liters. ABG value shows PaO2 of 73 millimeters of mercury, PaCO2 of 28, and a bicarbonate of 19 milliequivalents per liter, and pH of 7.46. So arterial oxygen to alveolar oxygen ratio is 0.23. So here the patient has a labored breathing and needs ventilation by CPAP or mechanical ventilation. So now, having said all these things, what are the initial modes we start the patient upon? What are its types? So the ventilator modes can be either volume cycled or a pressure cycled ventilation, and a combination of both volume or pressure cycled. Volume cycled is the one where the ventilator delivers a constant volume with each breath. And here the pressures, airway pressures may vary. And pressure cycled is the one where the ventilator delivers a constant pressure during each breath and the volume may vary. So this depends on patient's body size, diagnosis, pathophysiology, laboratory recordings, and initial ventilatory modes which we put the patient on are only served as starting points, and they are titrated to achieve the required targets. And the patient might need a full or partial ventilatory support. Depending upon those things, the patient can be put on initial ventilatory modes. So now the startup modes are volume control ventilation, pressure control ventilation, synchronized intermittent mandatory ventilation, and pressure support ventilation. The last one, that is the pressure support ventilation or a spontaneous mode, can also serve as a weaning mode. So factors to consider while we set up the initial ventilator parameters are level of support needed, whether the patient needs a full or partial ventilatory support, whether the patient can trigger their own breath, and what is the indication pathophysiology of the disease. And if there is any airflow limitation like an asthma or presence of air leak as in bronchopleural fistula, or if there is a neurotrauma which has a concern for elevated intracranial pressure. So now this screen shows you how a volume control ventilation works. Here in the volume control ventilation, we set up oxygen concentration, a peep, and a respiratory rate and a tidal volume. So this tidal volume is fixed. That is, the tidal volume is fixed at 6 to 8 ml per kg, and this is fixed. So the one in the side panel shows the parameters, which is the patient parameters. So here, if you see, so there is a peak pressure that is 34, which is variable because the volume is fixed. So this shows the mean pressure, peep, respiratory rate, oxygen, and minute ventilation. How much is the tidal inspiratory volume and how much is the tidal expiratory volume. So this is about the volume control ventilation. Now coming on to the pressure control ventilation. Pressure control ventilation, if you see the lower panel, here we set up the oxygen concentration, peep, and respiratory rate as in the volume control mode, and the pressure control above the peep is set. So here the pressure is fixed, and the side panel shows the respiratory rate is almost varying according to the breathing pattern or according to the compliance of the lung. So the pressure is fixed and the volume is variable. So if you see here, the pressure is, the peak pressure is 22, which is an addition of the peep and the pressure control, which we have set. And also you can see the varying tidal inspiratory volume and the tidal expiratory volume. This is about the pressure control ventilation. Now coming on to synchronized intermittent mandatory ventilation. Here, the ventilator allows the patient to breathe himself also. The patient might need a partial ventilatory support, and the ventilator allows the patient to breathe and support the ventilation which the patient triggers. And if the patient is not breathing, the ventilator delivers a machine breath. So this is synchronized intermittent mandatory ventilation. So there is an SIMV period where the machine delivers a breath, and there is a spontaneous period where the patient takes a breath, and then comes the SIMV period. So the synchronized intermittent mandatory ventilation can be pressure supported or volume supported. So here, if you see, the first breath is the machine breath where the trigger is time triggered or the machine triggered. And the second breath, if you notice, the pink line is the patient triggered breath. So, and the ventilation is supported by the machine. So now coming on to the fourth mode, which is the pressure control mode or the spontaneous mode. Here, the patient needs a partial ventilator support and the patient can breathe on his own. So all the breaths are patient triggered here, and the breath is supported by the ventilator. So here we set up only the oxygen concentration peep. That is, oxygen concentration is the FiO2, the peep, and the pressure support above the peep. And the patient triggers the breath. If suppose the patient does not breathe on a pressure support, then we set up the backup ventilation. So backup ventilation mode is the mode where the machine falls back to pressure control mode or a volume control mode, as we set, if the patient falls into apnea. So we set up an apnea time. If the patient has an apnea of more than 20 seconds or 30 seconds, as we set, then it falls back to a backup ventilation mode, which acts like a volume control or a pressure control mode. So what are the initial parameters which we set up while starting up the patient on mechanical ventilation? Those are the respiratory rate, tidal volume, sensitivity if the patient is put on partial ventilatory support, flow rate, flow waveform, and inspiratory and expiratory ratio. So there are a few triggers. Triggers are the ones which start up each breath. So what are those triggers? They can be either time triggered or patient triggered. Time triggered is the one where the ventilator initiates a breath, and the patient triggered breaths can be either flow triggered or pressure triggered. So what triggers a breath is what is called as trigger sensitivity. It's either time triggered or patient triggered. So time triggered is the one where the machine initiates a breath at a particular interval. So if we keep a respiratory rate of 15, which spans over 60 seconds, that is 1 minute, then the machine triggers breath at every 4th second. So this is time triggered breathing, which we set up in the control modes. So what is pressure triggering? Both pressure triggering and flow triggering are when the patient initiates a breath. So pressure triggering is the one where the pressure drop at the beginning of inspiration is sensed by the ventilator and it is triggered. It is supported. So this is pressure triggering. So if you see here in the inspiratory tubing, there is no negative pressure which is developed, and in the expiratory tubing, there is a -3 centimeters of water which is sensed by the ventilator and the breath is initiated. Now, flow triggering is one where there is a constant flow of airflow, and if the patient takes a breath, the drop in the airflow in the returned limb is calculated by the ventilator and is sensed as a breath. So now these are the settings: tidal volume, ventilator rate, peep, FiO2, inspiratory flow, trigger sensitivity, and pressure support levels, inspiratory pressures. So if you see here, tidal volume is set between 6 to 8 ml per kg in volume limited ventilation, and in pressure limited ventilation, the inspiratory pressure is set to target to achieve a desired tidal volume according to the pressure support. And respiratory rate, PEEP are all the same. And FiO2 we set according to the requirement, or if it is hypoxemic respiratory failure, we put the patient on higher FiO2. And inspiratory flow rate pattern to target an inspiratory-expiratory ratio of 1:2 or 1:3. And trigger sensitivity can be flow triggered or pressure triggered, and pressure support levels as we desire. So these are the initial parameters which we set the patient on ventilator, and they can be titrated as and when required to achieve the target SpO2, PaO2, and PCO2. So now coming on to the PEEP. Setting up an optimal PEEP. What is a PEEP? PEEP is the application of pressure at the end of expiration to prevent the airway collapse. So PEEP is positive end expiratory pressure, where we set up a required amount of pressure at the end of expiration to prevent the collapse of the alveoli. So if you see the respiratory breath pattern, this is the pressure volume loop where the pressure is plotted and volume is in the y-axis. The initial zone is the zone of atelectasis, and this is the least compliant zone. And then this point is called as a lower inflection point, after which there is a steep rise in the volume, and the change in volume per change in pressure will be very high. And then comes the upper inflection point. And after the upper inflection point is the less compliant area, where almost all the alveoli are kept open. So these are the three phases in a inspirator limb, and the next one is the expirator limb. Expirator limb, here is the upper deflection point and lower deflection point. So how to set up an optimal PEEP? So we can go for an incremental PEEP titration or a decremental PEEP titration. So the incremental PEEP titration, we monitor the compliance, driving pressure, SpO2, and other hemodynamic parameters. We set up an initial PEEP and then monitor all these things and increase the PEEP level every 5 minutes by 2 to 5 centimeters of water until the PEEP peak reaches to 40 or 50 centimeters of water. And decremental PEEP titration is we initially set up to a high PEEP, that is 40 to 50 centimeters of water, and then decrease by every 2 to 5 centimeters of water every 5 minutes, monitoring the compliance, driving pressure, and other hemodynamic parameters. So then comes the maintenance part. We maintain the patient on mechanical ventilation with sedation, analgesia, delirium management, hemodynamic monitoring, nutritional support, glucose control, and we take measures to prevent the ventilator-associated pneumonia, to prevent venous thromboembolism, gastrointestinal prophylaxis, required venous and arterial access, and temperature management. So coming to the last part, that is a weaning from mechanical ventilation. How do we define weaning from mechanical ventilation? This is the liberation of a patient from the mechanical ventilation, and it involves a 3-step process. So first is the readiness testing, and then the weaning and extubation. Readiness testing is the objective clinical criteria to determine whether the patient is ready to be weaned from the mechanical ventilation. And weaning is the process of decreasing the degree of ventilatory support we have provided and allowing the patient to take over the greater proportion of their own ventilation. And extubation is removal of the endotracheal tube and is the final step. So this is how a patient who is put on ventilator looks like. The patient is admitted for treatment of acute respiratory failure. Then the patient is maintained on ventilator, and the clinician suspects if the patient can be weaned and assess the readiness to wean. And we perform a spontaneous breathing test and extubate the patient, attempted only if the patient passes the SBT, and if it is required, then the patient is reintubated or the patient might be discharged. Almost 40% of this process is a weaning process, and it requires a careful planning. So now, when do we consider weaning? When there is an improvement in the underlying cause of respiratory failure, when there is adequate oxygen, and if the arterial pH stabilizes, and hemodynamic stability and ability of the patient to take spontaneous respiration. So thinking of all these things, what are the clinical criteria? As we started ventilation, we have a few criteria where we can assess the readiness for spontaneous breathing. So the cause for respiratory failure has improved. The PF ratio is more than 150 or 200, and the SpO2 is 90% with an FiO2 of 40%, and PEEP is less than 5 centimeters of water. Hemodynamic stability with low or no vasosuppressor medications, and ability to initiate a inspiratory effort. So additional criteria can be the hemoglobin level should be more than 7 grams per deciliter, temperature should be maintained, and the patient should be awake and alert and easily rousable. So subjective assessment, if the patient has an adequate cough, there is no neuromuscular blocking agents, absence of excessive tracheobronchial secretions, and reversal of the underlying cause. So objective criteria is PaCO2 of less than 50 millimeters of mercury with normal pH. The vital capacity is more than 10 ml per kg, a spontaneous tidal volume of more than 5 ml per kg, and a patient can generate a respiratory rate of less than 35 per minute, and F by VT. It is less than 100 breaths per minute per liter, and minute ventilation is less than 10 liters with a satisfactory blood gases. So this is the weaning path. Ready weaning, if there is reversal of respiratory failure, GCS is more than 8, spontaneous breathing, PF ratio is more than 200, there is hemodynamic stability. If this is achieved, then they pass on to the next step, which is ready breathing, where the patient is able to cough, O2 saturation is more than 90, respiratory rate is less than 35, PEEP is less than 8, and RSBI is less than 105. If these conditions are fulfilled, then comes the phase of ready extubation, that is successful 30 minutes SBT, that is spontaneous breathing trial. When the patient passes the spontaneous breathing trial, then the patient is ready for extubation and extubated. So these are the weaning predictors. There are measures of oxygenation and gas exchange, simple measures of respiratory system load, integrative indices, and complex measurements which may require special equipment. So we rely on the measures of oxygenation and gas exchange. That is PF ratio, alveolar to arterial pressure gradient, and dead space ventilation, that is dead space to tidal volume ratio. And most important of all the things is the rapid shallow breathing index, which is a integrative index. So RSBI is the one which I'm going to discuss now. This is a preferred weaning predictor. This is a rapid shallow breathing index, which is the ratio of respiratory frequency to the tidal volume. So this is measured by the tidal spirometer, or if the patient is connected to the ventilator, we can look for the tidal volume and the respiratory rate and calculate the RSBI index. The spirometer measures only the minute ventilation and the operator counts the actual respiratory rate. The tidal volume can be calculated by dividing the minute ventilation by the rate. So now how do we interpret the RSBI? RSBI of more than 105 breaths per minute per liter is likely to fail weaning, and a negative RSBI has a better predictive value. So I have two clinical criteria. So which of the patient has an RSBI? So if we see in the previous slide, RSBI more than 105 breaths per minute per liter is a negative RSBI and is likely to fail weaning. So here the patient, the first patient has a spontaneous tidal volume of 0.4 liters and a respiratory rate of 10 breaths per minute. So it comes to 25 breaths per minute per liter. And the second patient has a spontaneous tidal volume of 0.25 liters and the respiratory rate is 30 breaths per minute. So if we calculate RSBI for both the patients, then the second patient has an RSBI of 120, which is more than 105 and is likely to fail weaning. So now coming on to the spontaneous breathing trial. So this is the best indicator of ventilation discontinuation potential, where we simulate or we take off the patient from ventilatory support and observe the patient for a period of 30 to 120 minutes. So we monitor respiratory rate, blood pressure, heart rate, comfort of the patient, oxygenation, and SpO2. So spontaneous breathing trial is a short period of time in which the patient is breathing spontaneously, either with a minimal support or no support, and can be done when the patient is still connected to the ventilator circuit, or the patient can be removed from the circuit to put on an independent source of oxygen, that is TPs. If the patient is still on ventilator, the patient should have very minimal ventilatory settings like a pressure support of less than 5 to 7, around 5 to 7 centimeters of water, and 1 to 5 centimeters of water peep. The initial trial should last for 30 to 120 minutes. Almost 80% of the patient who can tolerate a 30 minutes SBT can be permanently removed from the ventilator. So when do we discontinue an SBT? Respiratory rate goes up, shoots up to more than 38 or 40. SpO2 falls to less than 92. A tidal volume generated is less than 325 ml. And a heart rate is increasing, that is 140 or 25% above the baseline. There is either hypotension or hypertension, a worsening agitation, anxiety and discomfort despite reassurances. So the patient can fall into one of these three criteria. The patient can be simply weaned, who is extubated on the first attempt without any difficulty. A difficult weaning is the one who patient or the patients who fail an initial weaning trial and can be weaned within 7 days from the first SBT. A prolonged weaning is when the patient fails 3 weaning attempts and requires more than 7 days to be weaned off after the first SBT. There are a few, one case report to indicate if the patient is ready to wean or if there is a failure of SBT. A 76-year-old man who has a history of COPD has been receiving ventilatory support for 4 days following an acute MI. So here the ventilatory settings are tidal volume of 500, mandatory ventilation of 8 breaths per minute, FaO2 of 0.5, and PEEP is 5 centimeters of water. ABG results are pH of 7.37, PaCO2 of 36, PaO2 of 78, and SpO2 of 93%. So the patient currently meets all the criteria for weaning and is placed on a TP's trial. Within 10 minutes, he develops restlessness, tachycardia, rapid shallow breathing, and diaphoresis. The SpO2 drops from 93 to 90 and the pulmonary artery occlusion pressure rises from 12 to 17 millimeters of mercury. So this patient has failed the SBT and is not ready to be weaned off the ventilator. So now, what are the signs of weaning failure? The patient can have tachypnea, use of accessory muscles, paradoxical abdominal movements, dyspnea, chest pain, asynchronous ventilation, and if the work of breathing can be measured, measured work of breathing can be more than 1.8 liters per kg, 1.8 liters kg per minute, or more than 15% of the total oxygen consumption. So weaning failure can be due to a respiratory load, cardiac load, or neuromuscular incompetence, critical illness, myopathy, or neuropsychological factors, or other metabolic and endocrine factors. So I have listed few causes of respiratory load, cardiac load, neuromuscular, neuropsychological, and others. So coming on to the last slide, this what is the role of diaphragmatic ultrasound in weaning? So we place a instrument which is similar to a Ryle's tube. There is an EMG cable attached to the tip of the instrument, which can measure the diaphragmatic contractions and can be seen in the ultrasound. Diaphragmatic excursions is dependent on the diaphragmatic contraction and inspired volume, and this can be used as a weaning predictor. So measurement of diaphragmatic excursions during a spontaneous unsupported breathing can be noted, and the patient can be weaned according to that. Thank you.